Hello, I'm Ian Paul, and this is the sixth and final module in the series on mood disorders. It focuses on the diagnostic description of bipolar disorders and their treatments. There are 4 objectives in this module. After you complete it, you should be able to identify the cardinal symptoms and epidemiological features of bipolar disorders. You should also be able to distinguish among the bipolar disorders based on observed symptomatology and etiological factors. Similarly, you should be able to explain the role of environmental factors in the etiology of bipolar disorders. Finally, you should be able to recognize and apply the appropriate treatment options for bipolar disorders. As a quick review, remember that normal mood is cyclic over time around a euthymic baseline. Mood disorders involve any disruption of that cycle. Previous modules have discussed depressive disorders in which that baseline is shifted down. This module will focus on the bipolar disorders in which there is significant exaggeration of the normal mood cycle. To expand on the illustration from the introductory module, let's look at a visual representation of the 3 primary bipolar disorders. The prototypical bipolar disorder, bipolar type 1, is shown by the red line with wide swings between mania or less severe hypomania and depression. Bipolar disorder type 2 has similar swings into depression and hypomania, but never results in a manic episode. Finally, there is cyclothymia, in which the exaggerated cycle swings between hypomania and dysthymia without the peaks of mania or the valleys of depression. As with the depressive disorders, the bipolar disorders can be grouped into those with no clearly identifiable trigger and those whose trigger is clearly substance-related or due to another medical condition. We'll start by discussing the bipolar disorders with no identifiable trigger, since those that have an identifiable trigger usually present the same symptoms as bipolar disorder type 1. The epidemiology of bipolar disorders is distinct from that of the depressive disorders. To begin with, unlike depressive disorder, men and women are equally affected by bipolar disorders. Bipolar disorders are also less common, with a lifetime prevalence between 1 and 3%. Notably, despite the dramatic appearance of manic or hypomanic episodes, the time a patient with bipolar disorder spends in depressive symptoms ranges from 3 to 1 for depression versus mania and 39 to 1 for depression versus hypomania. Because of this lopsided presentation of symptoms, bipolar disorders other than bipolar disorder type 1 are often missed on initial presentation or diagnosed as depressive disorder. It's also very important to realize that suicide is a major risk in patients with bipolar disorders. Between 20 and 60% of patients attempt suicide, and about 20% of untreated patients die from suicide. Like the depressive disorders, genetics plays a significant role in the emergence of bipolar disorders. If even one first-degree relative has a bipolar disorder, the lifetime risk roughly quadruples from the general population to 8%. Each additional close relative increases that risk. The brain structures and associated functions implicated in the bipolar disorders are similar to those of the depressive disorders. However, one major difference between bipolar and depressive disorders seems to be a diminished ability of the ventrolateral prefrontal cortex to control the activity of the amygdala and nucleus accumbens, leading to more pronounced effects on hedonic drive and anxiety. Likewise, the signaling systems so far implicated in bipolar disorders seem to be similar to depressive disorders, although the mechanism of action of the various mood stabilizers suggests that there may be other systems that have yet to be clearly tied to the bipolar disorders. The prototypic bipolar disorder is bipolar type 1. Its defining feature is the appearance of at least one manic episode. This is important to remember because patients with bipolar type 1 frequently also have hypomanic episodes and may never experience a full-blown depressive episode, although most do. The average age of onset is in the late teens or early 20s, but it can begin in childhood. Most cases are chronic, recurring over the lifetime, and as mentioned before, suicide is common. So what exactly do we mean when we talk about a manic episode? A manic episode is a distinct period during which there is an abnormally expansive or irritable mood with persistently increased goal-directed activity or energy. These symptoms must be apparent for at least a week and markedly impair functioning. However, although psychosis is possible, it is not necessary to define an episode. Typically, overall mood is either good or irritable. In DSM-5, 3 or more of the following symptoms are needed for a diagnosis of mania if mood is not irritable, and 4 or more if it is. Specifically, look for distractibility, impulsivity, or engaging in high-risk behaviors, grandiosity or inflated self-esteem. Patients often report racing thoughts or display a flight of ideas, often expressed as a greatly increased talking, often called pressured speech. As mentioned, patients in a manic episode often engage in an enormous amount of goal-directed activity and have very little need for sleep, often sleeping as little as 1 or 2 hours a night or not sleeping at all for 2 or more days. You can remember these symptoms with the mnemonic dig fast. Depressive or dysthymic episodes in bipolar disorders present the same as the depressive disorders, so use de Sigy-Cap's mnemonic to remember them. Bipolar disorder type 2 is similar to type 1 in its alternation between depressive and hypomanic episodes. However, crucially, it does not present with mania. Because of this, bipolar type 2 tends to be less impairing than type 1, and for that reason is often diagnosed later in life. Bipolar disorder type 2 has an onset in the early 20s on average, although it can begin much earlier in life. Like bipolar type 1, type 2 tends to be chronic. Only a small percentage of bipolar type 2 patients progress to type 1 with a manic episode. Hypomania shares the dig-fast symptomatology of mania, but the symptoms are less intense and only have to present for 4 or more days. In addition, functioning cannot be grossly impaired. Nonetheless, people in hypomanic episodes can display poor decision-making, particularly due to increased impulsivity. The mildest form of bipolar disorder is cyclothymia, which presents similar but fewer and milder symptoms than bipolar type 2. It can best be thought of as cycling between mild hypomanic and dysthymic symptoms. Characteristically, this pattern must appear for at least a year in children or adolescents, or 2 years in adults. The age of onset of cyclothymia is unusually young, first presenting in the early teen years, and it tends to be a lifelong condition. Unusually among the bipolar disorders, cyclothymia occurs more often in women than men. It's also important to remember that patients with cyclothymia are at high risk of progressing to more severe bipolar disorders. As mentioned earlier, bipolar symptoms can be associated with an identifiable trigger. Most commonly, these disorders present similar to bipolar type 1, specifically the manic episode. Quite a number of drugs of abuse, as well as psychoactive medications ranging from antidepressants to hallucinogens, can produce bipolar symptoms, most commonly the symptoms of mania. However, a surprising number of commonly used medications for somatic disorders can also trigger bipolar symptoms. Normally, bipolar symptoms subside and do not reappear after withdrawal of the causative agent. However, a number of patients with substance-induced bipolar symptoms go on to present with an ongoing bipolar disorder independent of the initial trigger. Patients who have had substance-induced bipolar symptoms should be counseled to be vigilant for the appearance of symptoms after withdrawal of the substance. A surprising number of somatic illnesses can result in bipolar symptomatology. Although some, like cardiovascular or Cushing's disease, are similar to those which can produce depressive symptomatology, a number of others, such as seizure disorders and Wilson's disease, can do so as well. It is somewhat less clear whether successful treatment of the underlying somatic condition produces long-term remission of bipolar disorders. That's the case with substance-induced bipolar disorders. This last section will broadly discuss the treatment options for the bipolar disorders. The treatment options and factors in clinical decision-making for the depressive symptoms of bipolar disorders are the same as those for depressive disorders. However, it's important to note that these are not recommended as monotherapies for depression because they usually do not control manic or hypomanic symptoms, and in some cases can precipitate a swing to mania or hypomania. All the same medications used in the depressive disorders can be used for the depressive symptoms of bipolar disorders. Likewise, the treatment rules are similar. However, be mindful of the fact that all of the first-line antidepressants, such as the SSRIs, SNRIs, and atypicals, as well as the first-generation antidepressants such as the tricyclics and MAOIs, can precipitate a manic episode. Moreover, they can do so at any time during treatment, so even if a patient does not display hypomania or mania in the first few weeks, that does not mean they may not months into treatment. So vigilance and monitoring is very important. Pharmacological management of bipolar disorders should normally include one of the mood stabilizers, such as lithium or carbamazepine, and combination therapy is frequently necessary. However, bear in mind that mood stabilizers tend to have more morbidity and risks of adverse effects than that of the first-line antidepressants. In part for that reason, a high number of patients with bipolar disorder receive antidepressants alone. However, there is little or no evidence to support this approach. Although mania has many treatment options, including both the mood stabilizers and antipsychotic agents, lithium stands out as the only drug used in bipolar disorder that has been shown in randomized clinical trials to significantly reduce suicidality. In addition, several second-generation antipsychotics or antipsychotic-antidepressant combinations are specifically validated for the treatment of bipolar depression. As with the depressive disorders, there are a number of evidence-based psychotherapies such as CBT and interpersonal and social rhythm therapy. In addition, psychoeducation and family-focused therapies are very important because therapeutic adherence can be more difficult with bipolar patients than others, and because the effects of hypomania and mania, as well as suicidality, can place major strain on family relations with the patient. This concludes the series of modules on mood disorders. You can find additional information on them in the Textbook of Psychiatry, as well as Current Diagnosis and Treatment Psychiatry, which are online at Rowland Library. Osmosis.org also has a good presentation with some clinical examples of bipolar disorder that you may want to check out.